Welcome everyone to CRRC's Summit of Strength virtual webinar series. This is Jessica from CRRC's Family Support Department, and we thank you all for joining with us today. We are incredibly thankful to our national presenting sponsors, Biogen, Genentech, and Novartis Gene Therapies, as well as platinum sponsor Scholar Rock for their support of the Summit of Strength virtual webinar series. We appreciate all of the questions we received in advance of this webinar, and we will try to answer as many as we can during the presentation. You are also able to submit questions throughout the webinar by using the chat box feature, which you can find located on your GoToWebinar toolbar. Please note that all lines will remain muted during the webinar other than for speakers. And if you have any additional questions after the presentation, please contact the CRRCMA Family Support Team by emailing familysupport@crrcma.org. And now we'd like to welcome our speaker, Vanessa Battista with Children's Hospital of Philadelphia, who will be presenting on pain management. Thanks, Vanessa.
Okay, thanks so much, Jessica. Is the audio okay? All right, great. So we're going to talk a little bit about pain today and pain management. And a lot of this is not specific to SMA because, as we all know, SMA is not something that has pain as one of its characteristics. So we don't always think about pain initially when we think about SMA or management of SMA, but we do know that people living with SMA can have pain based on some of the other things that are happening. So we never want to ignore pain. The most important piece to remember is that pain is subjective, and that means obviously it's whatever the person who's experiencing it tells you that it is. So pain is going to be very different for different people, and people will have a different threshold for pain, and there will also be different ways that pain is described. And so you want to be mindful of all of these things as you approach either a child or an adolescent or an adult living with SMA, that everyone will experience this differently, and some may not experience it at all. So it's not an assumption that people are having pain. It's just something that you always want to pay attention to. We know that pain can be both an emotional and a physical experience, and that it can be modulated or changed based on developmental, behavioral, psychological, familial, and cultural factors. So next slide, please. So definitions of pain: acute pain is pain that begins suddenly. There's usually a warning of some kind of threat, and that usually, by definition, acute pain is 3 months or less. Chronic pain is something that tends to last more than 3 months and last beyond just the stimulus or that threat or whatever that event may be. Recurrent pain is pain that alternates with pain-free periods, and total pain is something we hopefully don't see often, but that's suffering that's really on more than just the physical level, the physical, the emotional, the spiritual, and the social level as well. Next slide, please. So there's a lot of myths regarding pain. I'll just highlight a couple of them here. If you can distract someone, then it means they're not having pain. We know that's not true. Sleeping does not mean that someone is not having any pain. And how they're acting. Again, a lot of people act very stoic and may not show that they're having pain. We see this a lot in SMA with fractures, right? Someone may have a fracture and we have no idea. They're not screaming out in pain. It may be found incidentally, right? It's also a myth that pain builds character and that infants have a higher threshold for pain and that you'll always know when someone's in pain. That's also a myth. Medications are not always the best solution, and they are never not the best solution. So it's something you always want to consider as an option. Next slide, please. So this is just a little bit about the pathophysiology of pain, which I'm not going to get into in great detail, but there needs to be a stimulus first, a pain stimulus that stimulates nerve endings and then is transmitted through the spinal cord and tract and then into the cortex and the limbic system, where the individual experiencing this then recognizes or has a sensation of pain. Next slide, please. There are different types of pain, and this picture just really shows the different kinds and how you really split them out between nociceptive pain and non-nociceptive or neuropathic pain. And then on nociceptive pain, there's somatic and visceral, and in neuropathic pain, it's usually generally neuropathic, and is it central or peripheral pain there as well. Next slide, please. So about a little bit more in detail about the different kinds of pain. Somatic pain is usually described as a throbbing or aching. It can sometimes be sharp and it's usually well localized. So an arm, a leg, somewhere where there may be specific pain in one area. Visceral pain is usually not well localized, but we often describe visceral pain as meaning affecting the organs. So it's usually the abdominal area. Maybe, for example, someone's having liver pain or stomach pain. They can't necessarily tell you, especially if they're a child or someone younger, where specifically it is, but it tends to be that in that general area, but it's usually coming from an organ somewhere. And it's often described as a gnawing or cramping, intermittent pain. There may be nausea and vomiting, or there's a pressure-like feeling. And then neuropathic pain is that pins and needles, burning or numbness, aggravated by touch, can even sometimes be aggravated by clothing, or for example, the sheets on someone's feet. Those are examples of neuropathic pain, but that's more of your nerve-like shooting sharp pain. Next slide, please. So this is a little bit more about the common types of pain, and this is a chart that you can see when we're talking about acute pain. Usually musculoskeletal pain may be acute, and the normal pain reaction would be an injury, and then it gets better. So again, if it's acute, it's something that would, an accident, an incident, an injury, something that happened that then you would recover from. Chronic is going to be more persistent, and neuropathic is damage to nerves. So I've already mentioned most of these. Obviously, procedural pain would be from some specific procedure, and we may see that in the SMA population as well, right? And then there's referred pain that starts in one place, but is being referred someplace else on the body. And some of the physiologic changes that you may see or experience are listed here as well. So changes in vital signs, perhaps sweating, appetite changes, different things to look for different types of pain. Next slide, please. So usually untreated pain directly affects quality of life, and that can be in a variety of ways, and that can also be different for each individual experiencing it as well, and for their family, right? So someone may be getting less sleep because they're having pain. They may have a loss of independence or changes in their appetite, certainly changes in their mood, right? Most people, when they're experiencing a lot of pain, may not be in a very good mood because it's hard to focus on other things or feel happy if you're in pain. There can be stress on relationships, right? It can be hard to be with someone who's in pain all the time, or not knowing how to respond to them and how to appropriately manage their pain. And so these are all things that can certainly put a strain on someone's quality of life overall. Are they more dependent? Do they need more assistance? These are just things that, we have to really take into account when we think about this, because it's not just about the physical part of the pain and getting that under control. It's obviously your goal, but it is affecting many other areas of quality of life as well. Next slide, please. So how do you know when a child is in pain? And I'm going to talk also a little bit about adults, but starting with children, you want to do a very thorough pain assessment. In any age, you want to do a very thorough pain assessment, but beginning with children, how do we know when a child is having pain? So we're assuming that they maybe can't verbally tell us, but they may be crying or irritable or not sleeping well. There may be changes in feeding patterns, refusal to play or engage in normal activities, sleeping too much, so either not sleeping enough or sleeping too much, loss of independence, and again, some vital sign changes that you may see as well, tachycardia, tachypnea, hypertension, things you want to look for, and also ask always. You may not be able to ask the child directly, but you can also ask their caregiver, because they're going to be the one who notices the changes most in that young child, right? So you want to also be mindful of that, to always look for signs, and then certainly ask if you're unsure. Next slide, please. So when you're doing a thorough assessment, and this is in any age, you want to make sure that you look for certain things or ask about certain things. So you're either looking for these cues, or verbally someone's telling you about them. What's the location of the pain? Is it radiating anywhere? When was the onset? Describe it. So the things we just talked about, what's the character of that pain? Aggravating or alleviating symptoms, very helpful to know what's helped in the past or what's made it worse. what are the associated symptoms, so what are the other things that are going on, what's the timing of the pain, what's the environment. Sometimes people say they only have pain when they're outside in cold weather, or inside in warm weather, or whatever it may be, or outside in hot weather. It just depends on, you want to know those specifics as well, and what's the severity of the pain, certainly. Next slide. So the next couple of slides really just show some of the assessment scales that may be used to really assess pain. So we're starting with younger children and then moving up to adults here. This first scale is called the CRRC scale, which is the acronym. You can see what it stands for there. This is usually used in neonates or for post-operative pain, and this is something that you may be observing. They're not necessarily telling you. Again, if they're thinking about infants, you want to just observe these behaviors and then give them a score for their pain based on what you observe. Next slide, please. The FLAC scale is probably the most commonly one we see used in pediatrics. Again, the acronym is also there. This is generally used in ages 2 months up to 7 years, roughly, sometimes used a little bit older. But this is, again, an observation of behavior and figuring out what the total pain score is there based on for this particular scale. Next slide, please. This is the Wong-Baker-Facies pain scale. Most of you have probably seen this, whether you're an individual living with the SMA or a provider. You've probably commonly seen a pain scale. There's lots of different versions of this. Sometimes there's animal faces or different things, but this is the original Wong-Baker, named after the people who created it, and this is really a scale to point to. If they can't give you a definite number, you can also ask, does it hurt a little bit, does it hurt a lot, or just point to one of the faces and tell me how you feel based on that picture. Next slide, please. A visual analog scale is also something that's used, and again, this is used usually in as we get older, either adolescents or even adults. How severe is your pain today? And putting a mark somewhere on a line to indicate where you are. So you would just put a hashtag somewhere along that line from no pain to very severe pain. Next slide, please. This is a numeric scale, which we're probably most commonly familiar with here, or most commonly used, especially in adults or older, again, young adults, adolescents, up into older adults. But rate your pain on a scale of 0 to 10, with 10 being the worst pain ever and 0 being no pain at all. So there it's drawn out for you if someone needs to see it visually, but you can also just verbally ask this as well. So again, these are just things for you to be familiar with, different scales that are available. You want to use, if you're a provider or a practitioner, you want to be familiar with what's used in your practice setting and go with that. They're not all used everywhere, but you want to just be familiar with what's available and then use whatever you're most comfortable using that's available in your practice for you. Next slide, please. So you also want to ask people to keep a pain history, or if it's you yourself who's experiencing the pain, it's very helpful to keep a pain history. Along with all the scales that I just showed you, I think they're useful to go over to be familiar with them, but you need to know so much more than what's on that scale. Scales are very useful for an assessment of pain and also for looking at changes in pain. So I really want to know, if I'm using a scale, did the pain get any better or worse? It's really a marker of where someone was and where they might be now, but it's always going to be subjective to that individual person. And so keeping a pain history or a pain log is also very helpful to just really document all of this that's going on. What is, again, some of the things we talked about in taking a history? What's the quality or the nature of the pain? How long does it last? What makes it worse or better? But we see all the time, even when we're just assessing this in our own selves, I don't quite remember, how was it last week? Maybe it was Wednesday, maybe it was Tuesday. No, it was bad at night, or was it bad in the morning, right? We've all heard this story or run this through our own minds. And sometimes just keeping a pain, really a history log would be the appropriate way to put it. Is helpful to just really look at, again, changes over time and maybe make associations there when you're looking at the log of when was it better, when was it worse, and what was going on at that time. Next slide, please. Now we're going to start to talk about some of the medication or treatment for pain. You don't want pain to be extremely severe before treating. Sometimes people are hesitant. You yourself may be hesitant to take pain medication. You obviously don't want to go to either extreme with this where you're giving so much, but you also don't necessarily want to wait for pain to be really bad. You want to always try and stay ahead of pain. You want to give it at regular intervals to prevent pain from coming again before the next dose. So you don't want to wait for people to be in really extreme pain before you think about giving it another dose. You again want to try and stay ahead of it. Being mindful that there's no single medication or dose that works for everyone. You really have to figure out where you're starting and then either go up or down from there. And of course, always weighing the risks and potential side effects that may develop, and then have a plan for what you're going to do for those side effects as well. Next slide, please. So what do we do when we're treating pain? We're now going to shift from assessing pain into really the treatment options. And some of the possible concerns with treating pain that may either be concerns from the individual or you yourself living with SMA, or from the team that's trying to manage the pain for the individual living with SMA. Some of the concerns may be that treating pain means giving up. So a lot of people live by the philosophy of you have to be tough, you have to work through it, pick yourself up by your bootstraps sort of mentality, and that if I have to take pain medication, that means I'm weak or in some way giving up. I'm certainly not saying that that's true. It's just that's the mentality or concerns that people may have. There also may be misconceptions that opioids are too strong to give to children. So again, just from the pediatric perspective, that may be a concern. There's a fear of side effects. There's a fear of addiction, which I'm going to talk about. And then there may be cultural or religious beliefs surrounding the meaning of pain, why someone's experiencing pain, and how you treat that. That can be very much based in someone's culture as well. Next slide, please. So again, thinking about shifting from assessment to treatment, children may be unable to verbalize pain sensations, and so therefore their pain may be undertreated. That's really true in any population, but specifically in children, we may see that, or children or in populations where they're unable to speak or verbalize their pain, you will also see pain that's undertreated as well. Next slide, please. So what are the goals of treating pain? Well, the goal is often to completely eliminate pain, but you may not be able to do that. So we try not to promise people that we will 100% absolutely make them pain-free if they're having a lot of pain, because we can't always do that. And I think the expectation also for individuals and families is to not always expect that pain will completely go away. We often want to make that our goal and try and get there, but we can't always do that. So the goal may be just gaining a function or interactions, being able to be more social and not having pain interfere so much with your quality of life, to have minimal of any side effects from pain. And we often use pain scales to aid us there in figuring that out. What number or where on this scale do you need to be so that you would be able to do what you'd like to do? And so that's really the goal of where you're trying to get somebody. We don't start out with promising getting to 0, because we don't want to make promises we can't keep. What we do promise is that we'll work with you to try and make this as best as we possibly can, and to try and get you to be able to do the things that you want to do and live a full life and have a good quality of life without having pain interfere so much with that. Next slide, please. So these are some principles when we're thinking about pain relief, again, by medication. So pharmacologic pain relief here we're talking about. Usually we start with giving by mouth, although that we know that that may not be the only route, and I'm going to talk about that in a little bit as well. On the clock, which I already mentioned, you want to come up with usually a schedule. And again, it depends on the kind of pain. If someone's having intermittent pain, like I talked about earlier, that may not be persistent, maybe you're not giving it around the clock. But if someone's having chronic pain or acute pain, for that period of management, you do want to make sure that you're giving it regularly at regular appropriate time intervals so that you're staying ahead of the pain. You want to do, again, assessment scales or assessment pre and post. So what worked, what made it better, what made it worse, and then adapt the dosing or the plan as you need to based on that individual. And then pain medications should be prescribed with attention to all the details. So these are just some principles you always want to think about. The route, how are you giving it? When are you giving it? What's the scale you're using to measure a change? How are you dosing it for that particular individual? And what's the detail that you need to pay attention to? Next slide, please. So a little bit again about neonates and infants. I'm just looking at some specific populations. You want to be aware that they have immature hepatic systems, and so you're always starting with the smallest dose. It may depend on the medication and how it's cleared, but you want to be careful when you're dosing in this population specifically. They also have immature blood-brain barriers that can, for medications that do cross the blood-brain barrier, that's a concern, so you want to be mindful of that, and that infants may have a lower threshold for hypoventilation secondary to opioids. So again, just some special population things that you want to be aware of when prescribing. Next slide, please. So this is the World Health Organization pain ladder, and this has been around for many years, although it's changed a lot over time. And this is really, in some ways, you may call it the gold standard of how we consider pain management and how we start our plan for treating pain. Where do we start from? So we start on step 1, and some of you may be thinking this is not, we don't always do this now, but I'm going to show you in over the next couple of slides how this has changed over time. So we usually are starting with step 1. And then we would, which is a non-opioid or maybe an adjuvant or something else to help manage that pain. And then if that pain is persisting or getting worse, you would move to step 2. So next slide, please. Okay, sounds like there's an issue with the slides for a minute, so I can continue to talk about the pain ladder here, and hopefully then there's some technical difficulties. Hopefully they'll be able to figure that out in a moment. But in the meantime, I can continue to talk about the pain ladder. I'm not sure if someone could let me know, can people still hear me talking even though the slides aren't able to move? Okay, so should I continue presenting? Okay, great. So, okay, so when we're talking about the pain ladder, as I mentioned, we start with step 1, which is a non-opioid, and that's usually acetaminophen or ibuprofen. So non-steroidal anti-inflammatory drug or acetaminophen, and perhaps something else to help manage that pain that would be a non-opioid. That's your step 1. If pain is persisting or increasing, we would then go to step 2, which would be an opioid for mild to moderate pain, plus or minus a non-opioid. You may keep those other things on in the background. Okay, it looks like the slides are moving again. So if we can go back for just a minute. Great, thank you. So on the second step here, we might be talking about an opioid for mild to moderate pain, plus or minus a non-opioid, plus or minus an adjuvant again. If it's still getting worse or persisting from there, we would go to step 3, which would be, again, a different opioid. We now know that we have eliminated step 2, and I'll show you why. Next slide, please. So a few caveats, right? We know that pain affects all aspects of life. We know that it's multifactorial. We've talked about this. Finding the source can be difficult and complicated, and untreated pain can cause damage, affect function and quality of life. You want to try and learn skills to cope with chronic pain. That's essential because, again, we can't always promise to make this go away entirely. So you want to give people, or try and on your own develop tools and skills to try and have ways to cope with pain aside from just the medication management plan. There may be other techniques, which I'm going to go over at the end, that you can use, and also be aware that not everybody may have the words to express that pain. Next slide, please. So here we are, what I was talking about when our slides froze a moment ago. In step 1, it's acetaminophen or an NSAID, and then you want to dose appropriately by weight. In children and adults, it may be standard dose for these medications. Again, you want to just be aware of when you might not want to give these or not give these. For example, if someone has an issue with bleeding or GI upset or renal toxicity, you certainly want to be careful with the medications that you choose here. Next slide, please. So step 2, as I mentioned before, were other medications, so not necessarily the highest level of opioid management, but combination products, things like Nubane and Tramadol. And as I already gave it away that we've gotten rid of step 2, and I will tell you why in a moment. Next slide, please. So combination products are what's there in step 2, and we tend to not use these anymore, or try not to use these anymore, especially in younger children or when we're dosing by weight. And the reason being that you don't have the right balance necessarily in that combination between the opioid and the acetaminophen. And the examples of the medications that are commonly used in adults are listed there, but it's hard to figure out, for example, if you're giving somebody increasing amounts of Percocet for pain, they may hit the limit for the amount of acetaminophen that they can have in a day, but still need more pain medication. So oftentimes, as we told you, also using that stepladder approach, you may still be giving Tylenol or acetaminophen because that works well, in addition to this other medication that you're giving. And again, there may be the risk of getting too much acetaminophen. So in general, especially in pediatrics, again, where we're dosing by weight, even for adults, you want to make sure you don't have too much acetaminophen on board. We tend not to use combination products so that you have more control over how much you're giving of each thing there. So if we go to the next slide, you'll see that we have really eliminated step 2 and really now think about a non-opioid and then going to an opioid right to step 3. And of course, there's always an adjuvant. So there may be other things on board if you need to use them in some instances, but we really think about using a low dose of an opioid or starting there when someone's having increasing pain. Next slide, please. So opioids, this is really what everybody wants to know about when we're managing pain. Where do we start? What do we use? What do we do from here? What's the fear around when you say opioid? When you say morphine or hydromorphone, what do people worry about? So there's a lot to talk about and think about. So let's explore the opioids a little bit together here. Next slide, please. So opioids are going to work on different receptors, maybe mu receptors or kappa receptors or deltoid opioid receptors, depending on which specific medication you're using. These are widely distributed receptors throughout the central and peripheral nervous system. When you think about it this way, this is often why we have to switch pain medications, because sometimes receptors can become completely saturated and a pain medication may not work anymore. And so we switch to another one that may hit different receptors to try and still alleviate the pain. Next slide, please. So mu receptors are the primary site of action. That's the receptor we're usually getting at when we start with opioids. They modulate both the perception and the response to neuronal pain by suppressing GABA and NMDA, which is modulating N-methyl D-aspartate receptors. So you'll hear people mention the NMDA receptors and using specific medications to target those as well. So, if you're the individual living with pain, you don't necessarily have to worry about what specific receptors it is. The take-home point is to really just be mindful of the fact that there are different receptors, and this is why sometimes medications don't work well anymore and you need to try something else because it may just be too much hitting on one receptor repeatedly. Next slide, please. Okay, this is just a picture for you to see all those methods of action for those of you who are visual and like to think about that, but these are the different channels and how opioid action works when they bind to different receptors. Next slide, please. This is, again, the analgesic effect on different parts of the pain pathway. We talked a little bit about this earlier, but again, in thinking about those specific receptors, this shows areas where they may hit in different parts of the pain pathway. Next slide, please. So let's talk a little bit about neuropathic pain, because this is often the concern in SMA or for people with neuromuscular disorders, right? And neuropathic pain is really defined as an abnormal pain transmission. It's usually best treated with co-analgesia, so often an anticonvulsant and a tricyclic antidepressant. Can be also centrally generated, maybe sympathetic pain or a differentiation in pain as well. It's usually peripherally mediated, meaning that it may start somewhere and then shoot out from there. So these are things when you think about like nerve pain that may go down someone's leg or down somebody's arm. It may be stemming from the spinal cord, but that pain is going to be mediated along different nerve pathways throughout other areas of the body. So it may be centrally generated, but peripherally mediated, if that makes sense, and can be that sharp shooting electric pain. And this is the pain we're talking about in neuropathies. When someone has a neuropathy, for example, in their foot, it's usually starting somewhere in their spinal tract, but the pain is shooting out to the nerves in their foot or in their leg or wherever it may be. So treatment would be anticonvulsants. The biggest one that we use is probably gabapentin, or the brand name would be Neurontin. You've probably heard about that. It is in the class of anticonvulsant medications. We sometimes use pregabalin or Tegretol, and then antidepressants, usually tricyclic antidepressants or TCAs, can also be very useful in treating neuropathic pain. They're sometimes used together. Amitriptyline or nortriptyline are two TCAs that are very commonly used to treat neuropathic pain. What we see most commonly, though, is gabapentin. And I think the biggest caveat with gabapentin is to make sure that you're giving an adequate enough dose. We often see people on very small doses of gabapentin that aren't really enough to adequately get at their pain. You obviously, like everything else, want to start slow or start low and titrate up slowly. So you don't start with a whopping dose. You often increase gabapentin up to 3 times a day, but you may want to start with just 1 dose. The biggest side effects for gabapentin is it sometimes makes people a little bit sleepy. So you might want to start with just a nighttime dose and then gradually increase it as their body habituates to that. But you do really want to make sure that you're giving an adequate amount for it to really get at somebody's pain. For example, you may see a child who's on 100 milligrams. I'm not saying that's the right dose. I'm not giving specific doses. But a small child, when you're dosing by weight, maybe on 100 milligrams, you're obviously going to need more for a full-grown adult than 100 milligrams if you think about body distribution, right? So you really want to make sure that you're giving enough of this. We often see doses, and then people say, well, it doesn't work. Well, it's not working because you're not giving enough of it. So you want to make sure that you are at an appropriate dose there. Next slide, please. So general principles of using opioids, again, there'll be a lot of focus on opioids just because they are the gold standard for really treating pain. And you don't want people to necessarily be afraid of using them. We certainly don't say for everyone, okay, automatically you go on opioids, but for someone who's having chronic persistent pain or really severe acute pain, they are appropriate to be used. So I'm not saying all the things I'm going to show you here are necessarily what you absolutely want to be using, but I just want you to be familiar with the different options that are out there. So there's some general principles for starting with opioids as well. Obviously, pain that is persistent, you're going to use longer acting medications. For breakthrough pain that might be coming between those regularly scheduled doses, you're using shorter acting medications. And if there's not adequate relief or there's too many side effects, you want to think about switching to another opioid. And the right dose is the dose that works. Again, there's no one size fits all for this. You also want to be mindful that some pain medications are dosed in milligrams and some are dosed in micrograms. And so you want to pay attention to that difference, but also that you're not dosing in milliliters. So be very mindful of the concentration that you're using of that particular medication, just like any other medication, but you want to be really careful with that, especially in opioids, so that you're not giving way too much. Next slide, please. So here are the different opioids and the different routes that you can give them. Next slide, please. Starting off with morphine, this is really the gold standard. It's a pretty cheap medication. It's very readily accessible. It comes in lots of different forms and strengths, different forms, meaning sometimes it's sublingually, although that's not as available anymore, but you can give this lots of different ways. The usual interval is 3 to 4 hours for this, and it's metabolized in the liver, so you just want to be mindful in individuals who may have some liver issue, and there's histamine release with morphine, so that's why it may cause itching. That's one of the known side effects. Next slide, please. Hydromorphone or Dilaudid would be the brand name for that. Can be given PO or by mouth, by IV, or also subcutaneously. This is usually given every 3 to 6 hours. It's also it's hepatically metabolized and it's excreted in urine and feces. So just some main points about hydromorphone. Next slide, please. Oxycodone, this is only given by mouth, so this is very often something that we'll use for someone who's at home, having their pain managed at home versus in the hospital, because you can't give it by IV. So we often are, when someone's in the hospital and having severe pain, we would transition to many times oxycodone in order to go home. It's usually 4 to 6 hours. We're not entirely sure. The evidence isn't entirely conclusive there, but it's thought that there may be less histamine release and cause a little bit less itching than some of the other opioids, and it may be safer in significant renal failure. So you always want to have that caution there as well. Next slide, please. So fentanyl is, again, I'm sort of just giving a very broad overview of the different medications that are out there. This would probably not be used as much at home unless somebody's having really severe pain, but the biggest ones you're probably thinking about are things like morphine, hydromorphone, and oxycodone that we've just talked about. But fentanyl can be very helpful because it also comes in transdermal patches and can be used intranasally when there's times when you really can't get the medication in any other way. It has a very short half-life, so it's usually used for acute pain. It's not something that you're going to be taking or giving someone to take, prescribing for them to take, every 4 to 6 hours for an around-the-clock pain management plan. It's often used in procedural pain because it's quick acting, so quick on, quick off if someone has to have something done for a short period of time. So usually it's 30 minutes to 1 hour. So again, you're not sending somebody home with a plan on this, but you also want to know about the patch, because the patch can be very helpful. Patches, you don't have to remember to take the medication. Fentanyl patches can be useful, but you want to be cautious in using patches, because if someone's extremely skinny or cachectic, patches aren't always beneficial, or the dose that may be given can be too high. So you want to be careful with medications that are absorbed by fat. You want to be careful that you're not giving too much, and you don't have as much control when you're using a patch, because patches come off, right? And we find them on the bed sheets, or if you like to swim in the summertime, you're in the water, the patches may come off, and you don't know exactly where you are if the patch fell off to say, where are you in the interval of exactly how much medication you've gotten and how much more you need to get to be out of pain. So, they take a little while to kick in. They are great and can have a lot of benefit, but you want to just really think about when they're appropriate to be used. A lot of times in younger patients, we tend to put patches in the middle of the back where it's harder to reach, because kids and sometimes adults like to pick at things, and so they may take the patches off. And so we often place them somewhere where they're not so easy to just pull off, like on someone's arm. Next slide, please. Methadone, we don't always talk about this one, but I did include it because I know there was some interest in really hearing about the full range of opioids, and methadone is used a lot more commonly now than it was several years back. It can be given in many different routes, again, also orally, by IV. It is one that hits the NMDA receptors, so we often go to methadone when the other medications aren't working, for the reasons that I explained earlier, where those receptors may be completely saturated and we're switching to something else. It has a very long half-life, and so you cannot rapidly titrate up or down with methadone. We usually bring somebody inpatient if we're going to start them on methadone and observe them for at least 24 hours. It can take, 8 to 12 hours is when we usually dose it. So usually 2 to 3 times a day. When we're starting, we start with twice a day and then we work our way up to 3 times a day. But you really want to quickly observe, and you don't wake somebody up to give them another dose of methadone when you're starting this if they're completely asleep, because it can make people very sleepy. They will habituate to that, but the half-life, or the time it takes for the medication to really take effect, can be sometimes up to 48 hours with methadone. So it also can stack if you keep giving more. Then eventually it's going to all hit and you're going to be really zonked out. And so you obviously don't want to do that. You start slow with this and you gradually increase up from there. Can be very useful for bony pain. A lot of people find that methadone is the medication that works when all else has failed. So it can be something very useful to manage chronic pain, but it can also prolong QTC. So you want to be careful, and we always get an EKG when or check the heart when we're starting methadone. and it interacts with a lot of other medications, antifungal medications, things like that. So you always want to check that as well. And usually the clinical pharmacist is very helpful in dosing this. For individuals living with SMA or family members that may be listening, it's not something that you automatically go to. So you wouldn't want to walk into your provider's office and say, hey, how about some methadone today? It is an option, again, that I wanted to present for pain that may be severe or persistent or not responding to other things. But I don't think I've seen a lot of methadone prescribed in SMA because, again, we're not really thinking about pain being an inherent part of this disease. It may be pain caused by a contracture or fracture or something else that's going on. So next slide, please. So what are the side effects? They're listed there for you. Most of the treatment for the side effects from pain medication is going to be adjusting the dose. We sometimes will give other medications if we need to, but we try to avoid doing that. So you want to just watch for the side effects and make adjustments as needed. But respiratory depression can be a side effect if it's done appropriately. If the pain medication is prescribed appropriately, you usually don't see that, or you can see that, but it's not usually really problematic if you're titrating and prescribing appropriately doses. Nausea and vomiting, itching, urinary retention, and constipation are all things that can also happen. And a lot of these, you want to stay ahead of it and be aware of them. For example, when you start to prescribe an opioid, you always want to also have a plan on board for constipation as well, knowing that that's a well-known side effect. Next slide, please. This is a chart just to look at equal analgesia if you're interested in knowing the different doses and their equivalency in other medications. Next slide, please. And so let's talk a little bit about SMA here. What are some of the possible causes in SMA? I gave a lot of background on opioids because I know people often want to know about that and are fearful of prescribing them, but you may not always be using an opioid to treat pain in SMA. You may not be using one at all, or you may, depending on the severity or where the pain's coming from. So what are the things that we see? Again, it's not known for being part of the disease process, but you can see joint pain. Certainly scoliosis can cause pain, hip subluxation, contractures. Sometimes I'll make an audience when I'm giving a lecture stay with their arms up like this the entire lecture and, you know, hold fists, and eventually everybody's having pain, right, from staying like that. What does it feel like to have your, you know, contractures for hours on end? Eventually there's going to be some pain there. Fractures obviously can cause pain. Positional pain, not being moved enough. If you're not ambulatory anymore, are you having pain just from sitting all the time? Bony pain from different areas that may be pressing. Are you not sitting appropriately? Is the weight not distributed well? Equipment can certainly cause pain. Immobility, pressure sores, pain from procedures. So lots of things, again, that you want to look out for based on what else is going on. Next slide, please. So this is a little bit more detail about the different things that I just mentioned. So pain considerations in scoliosis, contractures, hip dislocation, just some examples. What are the things that we might do to treat the pain? So there are some medications that you may use listed there in that last column, but also you want to think about many different things. So physical therapy, occupational therapy. I said to one of our physical therapists before coming into this room to start this presentation, I said, I'm going in the other room to talk about you, right? And because when we think about management of pain, we're always thinking about physical therapy and occupational therapy, absolutely. Because when you look at that list of things I just showed you, so many of them are going to be managed by just appropriate equipment, movement, exercising, getting joints moving, orthotics, repositioning, sometimes hot or cold therapy, all these other things. So this is why this is an interdisciplinary approach, certainly, to the management of pain here. Next slide, please. So what are some of the non-pharmacologic adjuvants or things you would do, again, in addition to medications that we just talked about? I just mentioned physical therapy and occupational therapy, hot or cold, a TENS unit, which is like an electrical stimulation unit, are sometimes used and helpful, not always. And then the integrative therapies. And so we're going to talk a little bit about these because certainly the reason we call them integrative, you may have heard years ago we used to say alternative therapies, but the word alternative means instead of, right? It means something else. We now say integrative therapies because these kind of therapies should be used along with other things like medications or different physical therapy, occupational therapy, and those kind of things to have a really comprehensive plan to manage someone's pain. It is very rare where one of the integrative therapies may be the only thing that's used to manage somebody's pain, and it should also be really rare that medications are the only things used to manage pain. It's often a combination of some of these different things, because with a lot of the integrative therapies, we're really thinking about changing somebody's perception of pain. Next slide, please. So hot and cold therapy, which I mentioned, this may be a cold compress or warm or moist heat. You obviously want to be careful about this, not leaving things on too long, especially who may not be able to move body parts. Sometimes see you can have a burn from these things. I had one myself once from a heating pad. I fell asleep with it on and I woke up to the pain of a burn, right? And so you want to be really careful to not do what I did, right? To not have that happen, especially if it's someone you're taking care of, to leave these things on for too long. You want to think about, is it making it worse, right? When are you using hot or cold? If it's someone's having spasms in their pain or tension, cold may make it worse. If they're having inflammation, heat may make it worse. So you want to be mindful when you use these things, and usually 10 to 15 minutes on or off is the right thing. Next slide, please. So a little bit more about these integrative therapies. Next slide, please. This is acupuncture, right? Very commonly used to manage pain, very successful and helpful. Again, wouldn't be the only thing used to manage pain, but can be very helpful, and it can be done in children as well as adults. So you want to make sure it's an experienced acupuncturist. We in our hospital now offer this in both the inpatient and the outpatient setting, but usually it takes more than one treatment, so it's not a one and done thing, but can be very helpful for treating pain. Next slide, please. Guided imagery, which is the deliberate use of the imagination to help the mind and body heal, stay well, or perform well. So again, this is something that can be done on your own or with someone guiding you through it, but really just in your mind going someplace else. So using your imagination to try and not focus so much on the pain. And there's been a lot of success in using techniques like guided imagery or hypnosis to get through even procedures. I wouldn't necessarily recommend that as the only thing, but to get through some of these painful experiences, to really have your mind be someplace else and not be thinking about the pain so much. Next slide, please. So Reiki is something else that may be available in both inpatient or an outpatient setting. It is really an ancient healing art that involves gently laying hands with the intent to move energy. So there is some evidence behind all of these modalities. Of course, people have to believe in them or feel like they believe that they're going to help and want to try them. You don't want to force these on anybody. And you certainly, as an example, as the provider, you wouldn't want to say you absolutely need to go and get Reiki. If someone's interested in Reiki and brings that up, they can certainly consider that. Same thing with acupuncture, same thing with any of these. It's getting to know that individual, or getting to know yourself, or getting to know your child, and figuring out what works for you, right? Sometimes Reiki feels really good because it's just literally the act of laying still and having somebody work with the energy in your body. So we may not have, again, a lot of, there is some evidence, but it may not be the same as like looking at an opioid, but it's what's the type of pain? How is it affecting you? Is the pain caused by stress, right? If there's not a physical reason why there's pain and it's just stress related, some of these therapies may be really helpful to just get somebody to relax. Next slide, please. So therapeutic touch and massage, again, there is an art to these. If they're done inpatient, it needs to be somebody licensed who's able to do them. Also, if it's done outpatient as well, these can be really great, but you also want to be very careful, especially in not causing fractures, because we know sometimes fractures can happen very easily. So massage or therapeutic touch should only be done if somebody wants it, and it should also be done gently and appropriately. I know in our hospital, it's actually done through the physical therapy department when we get massage therapy for somebody. So it's people who are all trained in this, but you want to be use this appropriately, but be very careful. But with whoever's, if you're just looking up, going on Google and finding a local massage place, you want to be very careful that the person obviously is licensed, but also knows how to work with somebody who's living with a neuromuscular condition. And so you really use caution on this. It can be wonderful, but again, you want to just be careful you don't cause other problems. Next slide, please. Aromatherapy, which is the use of essential oils from plants to improve physical, emotional, and spiritual well-being, can be used clinically to try and manage, excuse me, or as part of a management plan for pain. You are not treating pain with aromatherapy. You are altering someone's perception, their feeling of well-being. And again, that's that stress and anxiety. When people have pain, or when you're living in pain, there's a component of anxiety, right? And the worse you feel, the more anxious you get. It starts to feel like, oh, now I'm worried about the pain. I'm having pain. I'm upset. And your heart rate goes up, and you see physiologic changes, right? And you can hear, I'm talking more rapidly, I'm describing increasing pain, right? And then some of these things are just used to try and calm somebody down and change their perception. In our hospital and many units, aromatherapy is available. We use mandarin and lavender that are both safe in children because we are a pediatric institution, and they're available very specifically without medical orders. They have to be documented when they're used, but so that patients or children or whoever it is, adolescents, are getting them quickly. And we fought very hard for that because they wanted to make them require a medical order, but you want to use this while you're waiting for the opioid to come up from pharmacy, right? These are things that can be used very quickly. If you're at home, you may have a little individual inhaler and can just take a breath of that anytime and start to feel calm while waiting for some of the other things to kick in if there's something else involved. Next slide, please. Okay, so that's about it. That was a very broad overview of pain management. Obviously, we could do a 1-hour talk on just one of the opioids alone. There's a lot of information to cover, and you really want to be careful that you have an appropriate plan in place that's managed by someone who knows how to do this well. Opioids and other medications and all these adjuvant therapies can be extremely beneficial, but they have to be used appropriately and with the appropriate fund of knowledge to make sure that you're not causing any harm. And again, they're not going to all be appropriate for everyone in the same way. And so I did go over all the opioids. Not everybody will be taking all of them, and probably many of you will never prescribe one or take one in your entire lifetime. But you want to just know that there are always more things that can be tried, and not have that fear of, oh no, if somebody says the word opioid, it means it's bad. They're very effective for pain management. If somebody's having severe and persistent pain, in many instances, you may not even go to prescribing something at all. And so there is a very big range there. So thank you so much. I appreciate you listening today, and I'm happy to take, I think, a couple of questions at this point.
Hi, Vanessa. Thank you so much for that very informative presentation and for helping navigate us through that short technical difficulty. We appreciate that so much. This is Sarah with the CRRC Family Support Department. And actually, I think we're going to just let everyone know, if you have any questions for Vanessa or any questions about this presentation, please feel free to send us an email at familysupport@crrsma.org. Thank you so much again, Vanessa.
Thank you.
Thank you. So next, we would like to introduce Joni Fusick, representing Genentech, who is going to be sharing their presentation and introduction to Evrysdi. Joni?
Thank you, Sarah, and thank you, CRRC, for hosting me today. Really appreciate it. Hi, everyone. I'm so happy you've joined the call today and have joined me to learn more about Evrysdi. I'm excited to tell you about it. Evrysdi has been proven to make a difference in infants, children, and adults with SMA. This is in people 2 months and older with a broad range of symptoms and motor function. Next slide, please. I'm Joni Fusick, as Sarah mentioned, and I'm a Partnership and Access Liaison, or PAL. I live in Portland, Oregon, and I provide support for people with SMA living in Washington, Oregon, Idaho, and Alaska. This is a photo of me and all my PAL teammates from across the country. So wherever you are, there's a PAL dedicated to provide support in your area. Each of us is the local main point of contact for Genentech, and we're here to support people living with SMA. Most of us have past experience as healthcare providers, but in our PAL roles, we won't be providing any medical advice. That's for your healthcare provider and their team. Our focus here is to teach you about Evrysdi so that you might be more knowledgeable and comfortable in your conversation with your healthcare provider. We also work with the rest of the MySMA support team to help you throughout the treatment journey. As you know, our time here today is relatively short. Next slide, please. So I'll give a brief overview, including what Evrysdi is, how it works, how it's being studied, and the study results so far. I'll review how Evrysdi is taken and what support services Genentech offers. If you want to learn more about Evrysdi, I encourage you to reach out to the PAL in your local area, and at the end of the presentation, I'll tell you how you can do that. First, we know that safety is top of mind for any medication you consider, so I'll start there. Next slide, please. Evrysdi is a prescription medicine used to treat spinal muscular atrophy in adults and children 2 months of age and older. It's not known if Evrysdi is safe and effective in children under 2 months of age. Before taking Evrysdi, tell your doctor if you have liver problems, are pregnant or plan to become pregnant, or are breastfeeding or plan to breastfeed. Evrysdi may harm an unborn or breastfed baby. Evrysdi may affect a man's ability to have children. Tell your doctor about all medicines you take. These are not all the possible side effects of Evrysdi, so please refer to the additional safety information throughout this presentation and in the full prescribing information that can be found at evrysdi.com. Now let's talk about how Evrysdi works. Next slide, please. As most of you know, the effects of SMA are caused by not having enough of a key protein called survival motor neuron, or SMN. Evrysdi is designed to work by helping to make and maintain more SMN protein. And in animal studies, Evrysdi was distributed throughout the body. In clinical studies, Evrysdi increased and maintained levels of SMN protein. Within 4 weeks of starting Evrysdi, median SMN protein levels more than doubled and were maintained throughout 12 months of the studies across all SMA types. Next slide, please. Evrysdi studies are ongoing, and it's being studied in a broad range of infants, children, and adults with SMA. More than 450 people with type 1, type 2, or 3 from ages 2 months to 60 years are being studied for safety. And efficacy or effectiveness of Evrysdi has been studied in people from ages 2 months to 25 years old. Next slide, please. Evrysdi received FDA approval based on the results from the first 12 months of 2 ongoing studies. The first is Firefish for infants with type 1 SMA. This is a 2-part open-label study, meaning participants and researchers know they are receiving Evrysdi. There are 62 infants in total, 2 to 7 months old, with type 1 SMA. Part 1 included 21 infants and explored the recommended dose of Evrysdi. The safety and effectiveness of Evrysdi after 12 months on treatment was also measured. Part 2 includes 41 infants and is measuring the safety and effectiveness of Evrysdi at the recommended dose. The second study is Sunfish. This is for children and adults with type 2 or 3 SMA. This is also a 2-part study and included 231 children ages 2 to 25 years. This study is different in that it's randomized and placebo-controlled, meaning there are 2 groups, one group receiving Evrysdi and one group receiving a liquid that has no active medicine in it, or it's called a placebo. People are chosen randomly to receive either Evrysdi or the placebo, and comparisons are made between the 2 groups. Part 2 includes 180 people and is measuring the safety and effectiveness of Evrysdi at the recommended dose. There are 128 people with type 2 and 52 people with type 3 SMA. There's a third supportive study called Jewelfish that is currently looking at the safety for Evrysdi for people with type 1, 2, or 3 SMA who've been previously treated with other SMA medications. So this is how the studies were set up. Now let's talk about some of the results. Next slide, please. In Firefish Part 1, Evrysdi helped infants with type 1 SMA achieve a key motor milestone. 41% of infants were able to sit for at least 5 seconds without support, after taking Evrysdi for 12 months at the recommended dose. As you may know, infants with type 1 SMA who do not receive treatment are not expected to sit without support. There are also some other observations during the study. Next slide, please. Evrysdi helped infants survive without permanent breathing support. At 12 months, 90% of infants in the study were alive and could breathe without permanent support. At 23 months, 81% were alive and could breathe without permanent support. Now we'll review the results of in children and adults with type 2 or 3 SMA who were part of the Sunfish study. Next slide. In the study, children and adults treated with Evrysdi showed improved motor function versus those not taking Evrysdi. This was measured over 12 months and based on a motor function scale called the MFM32. The MFM32 scale includes 32 different elements to assess head, trunk, and upper limb movement. At the end of 12 months, average scores on this scale increased by 1.36 points for people taking Evrysdi, and for those not taking Evrysdi or the placebo, the average scores decreased by 0.19 points. You can see this difference at the 12-month mark on the line graph and on the arrows next to it, where the top blue line represents people taking Evrysdi and the bottom gray line represents people that were taking the placebo or not taking Evrysdi. As we talked about it in the beginning, we know safety is top of mind for any medication you consider. So let's talk a little bit more about that next. Next slide. As I outlined before, Evrysdi is being studied in people from 2 months to 60 years old with type 1, 2, or 3 SMA. For infants with type 1 SMA or infantile onset, the most common side effects of Evrysdi are fever, diarrhea, rash, symptoms of upper respiratory infection like runny nose, sneezing, sore throat, and cough, lung infection, constipation, and vomiting. For children and adults with type 2 or 3 SMA or later onset, the most common side effects are fever, diarrhea, and rash. These aren't all the possible side effects of Evrysdi, so when you're considering or taking medication, it's important that you have a discussion with your healthcare provider or pharmacist about the balance between safety and effectiveness. One thing to note is that no one stopped taking Evrysdi because of side effects in the main clinical studies after 12 months of taking Evrysdi. Also, as I mentioned before, safety in people previously treated with other SMA medications is currently being studied. Next slide, please. Evrysdi is a first and only medication to treat SMA at home with at-home dosing. It's a liquid treatment that can be taken by mouth or feeding tube, and because it's taken at home, Evrysdi would be delivered directly to you, stored in the refrigerator, and then you would measure and take your dose once each day using the syringes provided in each shipment. As you all know, treatment for SMA is a journey, and Genentech offers a number of support services, collectively known as My SMA Support, to help support you along this journey. Next slide, please. My SMA Support is here for you. Pals like me are the main point of contact for My SMA Support. My team and I are able to help provide product education, information on insurance and financial assistance, coordination with specialty pharmacy for deliveries, and other support. We're able to meet with you virtually in a one-to-one setting or with other family members. And we can do this through Zoom or other virtual platform that you're familiar with, or just simply have conversations by phone. One reminder, though, is that PAL support doesn't include any medical advice. Your personal healthcare provider should always be your main source of questions about your health and medical care. So we've covered a lot of different things in a short time. Let's quickly review. Next slide, please. Evrysdi has been proven to make a difference in infants, children, and adults with SMA. It improved motor function scores in 2 main studies in infants, children, and adults. 41% of infants treated with the recommended dose were able to sit for at least 5 seconds without support. 90% of infants at 12 months and 81% of infants at 23 months were alive and able to breathe without permanent support. Motor function improved in children and adults after 12 months of treatment with Evrysdi. Evrysdi increased and maintained SMN protein levels in clinical studies. Safety of Evrysdi is being studied in people 2 months to 60 years old with type 1, 2, or 3 SMA. Evrysdi is the first and only oral treatment for SMA delivered to you and taken at home. Again, this has been a lot of information, so I would encourage you to contact the PAL in your local area and talk with your healthcare provider to learn more about Evrysdi. To contact your PAL, visit Evrysdi.com and use the Sign Up or Find a PAL feature. Next slide, please. I just want to thank you all for your time and attention today, and thank you to Cure SMA for hosting me. I hope you have a great rest of your day, and I'll turn it back to Sarah to close.
Thank you so much, Joni. And thank you again to Joni and Vanessa for your fantastic presentations and your time with us today. We appreciate everyone who joined in on this webinar as well. You'll all be receiving a follow-up email with a survey link, and we would greatly welcome any feedback that you have. We're also incredibly thankful for the support from our sponsors for making the Summit of Strength virtual webinar series possible. If you have any further questions or if there's anything we can do for you, please email us at familysupport@curesma.org. Have a great day, everyone.